I'd like to thank the organisers very much for offering the Wound Management Innovation CRC the opportunity to present a workshop at today's the conference. It's a great opportunity to be able to talk about something that's very near and dear to the speakers that we have today. And I thought I'd just briefly tell you about the format for today, because the title doesn't really give away a lot. What we're hoping to do is to, with the goal of talking about how it is possible to improve wound management within the primary healthcare setting. We'd like to talk to you about a pilot project that some of you may have already known about from last year's conference. But we have a lot more information to share now. So a project, and we'll be looking at it from different perspectives. So I'm just going to do an introduction and just a brief overview of the project and some of the results so far. And then, more importantly, I'll be handing over to Patrice, who will be talking about the journey, I guess, from her perspective as a practice owner, practice manager, practice nurse. And then Nicola Morley will be talking about it from the wound expert perspective. Nicola is a nurse practitioner, vascular nurse practitioner here on the Gold Coast, and has been the wound expert involved in the education and coaching side of things for the project we'll be talking about. And then Allison Oakes will be talking about her journey in this process. And Alison is a practice nurse from Tasmania and has gone through the journey, has done some amazingly wonderful things in her practice. So we're really glad to be able to provide you with the different perspectives in this really important area. Okay, and then we will have time at the end, hopefully about 15 minutes or so at the end for questions and discussion from the floor and with the speakers. Okay. So before I start, I'd like to acknowledge a lot of different groups who've been involved in this work. And I could probably have about 5 slides if we included everybody's name, but that I don't have time for that. So just briefly, the Wound Management Innovation Cooperative Research Centre, who funded a lot of this work. The AML Alliance, even though we know they no longer exist, really championed this work and got it started, which, you know, we're really indebted to them and Lynn Walker especially, who really got this up and running. Medicare locals, we've worked with a number of Medicare locals around Australia in this project, and they really played a pivotal role in raising the issue and linking us up with the GP practices involved. The wound experts, Nicola is one of 3 wound experts who've been involved in this project, and they're all nurse practitioners and incredibly passionate about wounds and like the most gory things that you can imagine. I'm not a nurse by background, I'm a dietitian, so I like looking at food. I don't like looking so much at gory wounds. So, and warning is there is some photos of some pretty gory wounds in this presentation. But nurses all seem to love that, so that's good. The general practice sites, so altogether we had 7 sites involved in this project around Australia. And, you know, a lot of these sites were new to research, and it involved a lot of extra work in accommodating the actual data collection side of things, and annoying people like me ringing up asking if they'd sent their forms in and things like that. So very much like to thank them. Wound product device companies came to the party and provided quite a lot of devices and products during the pilot program. Champions for Skin Integrity project is one that's been rolled out around Australia, and we've used a lot of their excellent evidence-based resources. Connecting Wound Care Project's a Victorian project, and we used a lot of their resources. And QUT, which is where I'm employed, and the Queensland University of Technology, for non-Queenslanders. So and there's probably others we need to thank. So it's been a really collaborative project. Okay, so this is what we hope to cover today, and I think I've briefly outlined that already. So we'll be looking at wound management in general practice from different perspectives. Okay, just a little bit about the actual cooperative wound clinic model, and it is only one model. this was just something that we tried, but really, there are many, many ways that wound management can be addressed and looked at in a different way in the general practice setting. But this is the model that we sort of tried. So the key, I guess, principles about it were that it involved nurse-led clinics, that there was a big education focus for the patients as well as for the nurses and the GPs. In a lot of practices, the GPs were quite actively involved. And the business model and sustainability is really important as well, because obviously, this isn't going to keep going if it's not at least paying for itself in that model. So that was an important aspect. Okay, so it involved dedicated clinic time and holistic evidence-based care, as I said, education focus, and a really important part of this, and Nicola will talk about this as well, is that referral pathway, what is appropriate to be managed in the general practice setting and what really should be referred on. And that was one of the really key parts with it. Just to give you an idea of the timelines, we started the work in May in Victoria, and then expanded a bit more in Victoria, and then it came to Brisbane, and then it went to Tasmania. So we had great buy-in involvement with the Medicare locals in each of those areas, and the pilot information is now, the data from that has, because it, fairly recently, well, that's when it started, so the 6-month period only finished in about February, I think. So the data from that is now being analysed, and it will be, there'll be papers written and all sorts of things, because we went through ethics, we had all the right research boxes ticked for that. So we have some data now, and I'll just talk briefly about that. So the good news was, from the staffing point of view, that it was very positive, that the nurses, mainly, we did get some we did pre and post questionnaires, and we did get some posts from GPs, but not many. But most of our target audience really was the practice nurses, and certainly showed that their confidence levels and their knowledge improved significantly. We used a case study, and we showed in the post there was a lot more detailed answers to the questions compared to the pre. So it was a nice response. And they're just a few quotes, so from the staff. I can let you read those. Okay, so from the patient data, and this is very recent data as of yesterday, that I was able to get some information out of the database, that in total we had 71 patients, 89 wounds, so obviously some patients had more than one wound, and 7 clinics. A lot of the patients, and this is no surprise to anyone here, had significant comorbidities, so we're not just dealing with a wound, we're dealing with the whole patient and all the other background that they have in terms of health risks. So there was a wide range of wounds, and Nicola will talk a little bit more about that from the Brisbane perspective. The 2 most common ones are venous leg ulcers and pressure injuries. 22% of all the wounds were recurrent, so the patients had previous wounds. And the mean duration, you can see the range is huge, that's why I included it. So because there was such a variety of different types of wounds, they range from 2 to 208 weeks. So some people came to the clinics and they'd had their wounds for 2 years. So, that we're not talking about short-term issues here. Okay, so some good news. Almost half the patients received ABPI or referral for further vascular investigations. And you may ask why not more? And there's lots of practical reasons, including, I think only one of the sites, which was actually Patrice's site, actually already had a Doppler. I don't think any of the Tasmanian ones. You bought one, yes. Yeah. Yeah. So if you don't have a machine, that's pretty hard to do them. But and then if you do have a machine, you have to know how to use it and how to interpret it. So there was a lot of reasons for that. So most patients did receive good quality education. As an education person, that was really what I was very keen for for patients to actually get information, and there isn't a lot out there. You don't generally see it sort of lying around, high-quality recent information on wound management, but it does exist, and I can tell you where to find it if you would like to know. Compression therapy was recommended where indicated 38% were treated with high-level compression. So again, I'm sure you all know practical reasons for that. Nicola will talk more about that. The healing data isn't as clear-cut as what we'd like to see. In our pilot, our early 40% healed, and Nicola's, the Brisbane site was about over 70% healing rate within the 6-month period. So that's pretty impressive. And both staff and patients, because we also did a patient satisfaction survey, felt that the model resulted in better outcomes. And in fact, the patient satisfaction is really impressive, like 95% feeling that they felt it, it really was a lot better care than what they might have received previously or for other wounds. Okay, the reality is that actually a big part of this was actually using a wound assessment form, which again is available, and I'll tell you where you can get it. But actually using that and recording the information in a busy GP practice isn't as easy, and particularly with a research focus, isn't as easy as what we ideally would have liked. So getting that detailed information clinically was challenging. Many of the patients had comorbidities and other issues, language issues and all sorts of other issues. The cost of dressings always comes up as a major factor, particularly in the bulk bill setting. And one of the part of the model that we were trying to push was socialisation between the patients, trying to get them talking to each other and receiving their treatment within one room, but that generally doesn't work too well. So we sort of decided not to push that as much by the later sites. But in the research done prior to this, that showed that actually did have a significant impact on healing rates and recurrence rates. So impressions, and I'm sure everyone will say the same sort of thing, so I won't dwell on this, is that it really requires a whole team approach for it to be successful, and GP support is crucial, and I think Alison has nice stories about the support she's received from her GPs. For them, I think it was much more of a retention exercise to make sure Alison stayed in their practice. And practice manager, reception staff are vital in terms of, I guess getting, from us in the research side, were vital in terms of getting the information required, but also vital in terms of promoting it and the booking and all that sort of stuff. So having a local wound expert, if you don't know if you have one, generally you will have one within your area, and linking with them and inviting them to be involved can make it have a major impact. Space and equipment is required, and it does take time to do a good wound assessment. That's the reality of it. And the cost of dressing does need to be considered, and I think I'm going to talk more a bit about that. Okay, and just to finish off, there were a couple of resources that came out of this, and this resource kit was produced. It's currently sitting on the Southwest Melbourne Medicare local site because we did this in conjunction with them and they had some funding for it, and it's still there. I checked yesterday. I have a couple of copies that I've printed off, but it runs through. It's got all the wound assessment forms. It's got referral guidelines. It's got links to where you can get really good patient information. So if you haven't seen this already, I'd recommend you go into the Southwest Melbourne Medicare local site and look under their resources, and you'll find it under wound management. And Nicola also prepared a fantastic summary of the types of wounds in general practice that covers assessment and management options. It's also got links to evidence-based guidelines and published standards of care and all of that sort of thing for the common wounds. We were hoping to turn this into an app, which we thought would be really important. So if anyone knows anyone that would be interested in funding an app to be developed from this, that would be good, because the Wound Management Innovation CRC has gone down a slightly different pathway now. So I don't think we're going to get funding from them, but the content's there and it's great. So if you're interested in that, please catch up with myself or Nicola and we can get that to you. Okay, so I'll hand over to Patrice now.
Wasn't expecting such a full room, so thanks for making me a little bit nervous. I'll just go through this, which I haven't read it since I wrote it. I apologise, but I have delivered various versions of this around the traps since we did the pilot, so I might speak to the slides and I might not. This is my little practice, my very neat waiting room and my very neat treatment room with no patients. It was obviously taken quite early in the morning. Okay, a little bit about us, snapshot. We've been around since 1998. We had, at the time of this pilot, we had 10 GPs. We had training registrars at that time, currently don't have them. 5 registered nurses. I count myself in then, but sometimes, you know, the doctors come out to the treatment room and say, is there a nurse here? And I go, I'm here. And they go, no, we actually want a real nurse. And just, you know, average garden variety general practice in the south side of Brisbane. We are actively participate in everything. If someone said, like Karen rings me up and says, I've got this thing, are you interested in wound care management? I think we can do some improvement. Well, hell yes, I'm very interested in that. All my registered nurses are obviously active members of APNA. They wouldn't dare not be. So Karen's spoken a bit about the CRC pilot, how we got involved. She was looking for sites in Brisbane. I do sit on our Metro South Medicare local board, so I was kind of conflicted there, and I said, well, I'd like to put my hand up. I had to step away from it. Our practice went through the selection process, as did the other practices, and luckily for us, we were chosen along with another site because they couldn't split the two of us because we were both good sites to do it. The downside of this was we had to share Nicola with the other site. We could have had her every week, but we only got her fortnightly. The upside was the collaboration with the local practice 5 kilometres down the road that we would never normally have anything to do with, but it got nurses in local practices talking to each other and sharing ideas and sharing resources, and that was a really good sort of formal/informal networking start, and that's continued on. So before the wound CRC pilot started, nothing that you don't know about how treatment rooms booked. The patients were booked in at times that suited them or times that suited the doctors, and the doctors and nurses managed the wounds. They all had different opinions and different levels of ability to manage the wounds and personal biases, and you would know that one GP treats it with something and the next one comes in the next day and says, well, I don't want to do that. I want to use this, regardless of what the evidence might show. Some patients' treatment was not consistent, and some certainly did not represent contemporary practice. And we sent the difficult wounds on to the local hospitals. Public hospitals where we are have 5 to 6 month waiting list, and it was just that vicious circle of sending them on and they get worse and they don't get better and they just linger on in the system. Or they'd go to a podiatrist who might not refer back to us, and then the patient had come back with some sort of mixed up story about what we were supposed to be doing. And then we got the patients who manage their own, and we all know how that ends up. So we agreed to be a trial practice. It was surprisingly met with some reticence from the GPs, who I sort of went into the staff room and went, we're doing a wound management trial, okay guys? Someone will be here next Wednesday. And they all looked at me and went, what's she up to now? And they gave me a bit of, you know, how's this going to complicate our day, as they do, rather than, well, I'm trying to fix your day, rather than complicate it. So I did have a bit of apathy there to start with. The nurses, conversely, were really excited that they'd be getting a nurse practitioner coming to visit them on site. We had a bit of housekeeping to do. We had a look and looked at our frequent flyers and thought, who are going to be the best people to benefit from this? Who are we going to learn from? Who can we actually get some real traction in this program? So we booked them in fortnightly in the clinic styles. Obviously they would come, you know, at other times from that fortnight, but we made sure that they were there when Nicola was there, when the treating nurses were there, so that the education opportunities were there. We had 13 clinics over 6 months. and we had 11 patients that we identified as in those clinic. There were other ad hoc patients that Nicola would see if she was there during that time, but these were the 11 clinic patients. We had diabetic ulcers, we had a pressure wound on one lady, we had a pilonidal sinus. The pressure wound is an interesting story that I think Nicola's going to delve into, and probably got a photo or two of this lady's heel, but it was the biggest wound that we've ever seen. I think her wound lingered around for 2 years prior to this intervention, and by the end of the 6 months, her wound was gone. And that was just amazing, and hats off to that lady. Here's one of my nurses in action. This gentleman with his diabetic ulcer and his 200 cigarettes per day habit has subsequently had 2 fempop bypasses. His most recent one, I saw him in the treatment room a couple of weeks ago, and of course his wound was sort of almost dehiscing because he walks out the front and has another cigarette. There was another man with a similar wound that Nicola will talk to, but one healed and one didn't. Go figure. So real-time evaluation, we had high quality education being imparted in the workplace for the nursing and doctors. The holistic assessment and the approach to wound care led to care pathways being identified earlier in some cases, such as the gentleman on the slide before, and better treatment was received in a hurry, that we got them to skip up those 5 to 6 month waiting lines. The high quality, timely, effective patient education was delivered, and the patients learnt about why they had an ulcer on their foot, how it was related to their diabetes, what they could do to avoid it, how they could change their lifestyle to perhaps not be in this position again. And the patient actually became a really active member of their wound team. And Nicola, again, will show you some of the tools that we've made during that time. And I think you'll talk about the other stuff we did for Marina as far as the...
Multidisciplinary stuff.
Yeah. And we got independent advice about the products on the wound rather than the reps coming in and saying, you got to buy this off me, it's really expensive, and not much more information. We got, this is the type of product that you can buy, this is what you should be looking for this type of wound, and then we can go out and source our own most effective rather than having it, the supplier saying this is the only one that you can get and this is how much it's going to cost. So that's been really effective ongoing too. Post, the peer-to-peer learning has been amazing. We've had positive feedback from all of the clinicians. The doctors are now, and I'm not bagging my doctors because they're all excellent and they're all very much into collaborative care. However, now they are very much coming into the waiting room saying, what do you think, to the waiting room, what do you call it, treatment room, what do you think we should do on this? I'll sort of leave it to you, I'll oversee it, but I trust your expertise in this area. And there's a genuine desire amongst all of the clinicians to maintain this higher level of wound care. Is that it? Or no, I just pushed the wrong button. There are a couple of quotes you can read from very experienced RNs and GPs, and when I went in and said, give me a quote, quick, I've got to do this thing, I was really quite pleased that they gave me very nice quotes. Speed reading, I'll move on. Post-intervention, the potential for this type of project for research at design level for professional development programs for primary healthcare nurses is untapped, and it's urgently needed, I believe, and I think that's something that, we're certainly discussing it at APNA, but, we discussed amongst ourselves as professionals as well. Access to the primary healthcare workforce could be done in partnership with bodies such as ourselves and the college and the primary healthcare networks, now that we know that they are really going to exist, and in collaboration with universities and the CRC. There's potential there for the private sector as well, because they do get to sell their product if it works. And as you all know, the fiscal cost of wound management is often borne by the practice for patients who can't afford these expensive dressings. But when you have them in a situation like this, and you can say, and especially if they're a diabetic who's had an ulcer before, and you can say, I know it's going to cost $65, but I can guarantee you'll be out of here in 4.5 weeks, not 4.5 months. There's a lot of power to that, and we found that our patients at the end of the 6 months were really quite receptive to that. And I think I was talking to Julianne B and Sam earlier today, and we were discussing clever ways of the one-use only, you know, your Solicite, draw it out with a 2 ml syringe and put the thing back on. You don't have infection control problems then, or save your very expensive dressings in a Ziploc bag so that you can actually get multi-use out of single-use things. Briefly, 6-month intervention, 11 patients, 15 clinicians upskilled. Only 2 of those patients went to hospital, the FemPop bypass and the sinus. And I would say out of the 9 that didn't, quite possibly 7 of them would have if we hadn't had this intervention. Yeah, and I think more importantly, the clinicians report consistently that the patients are still receiving really high wound quality. The duration, and anecdotally they're telling me that the duration of healing is dramatically reduced. If I was a bit more research inclined, I probably would be writing down this data, but, you know, I'm not research inclined. Referrals to the acute sector have dropped, and I have been talking to Queensland Health about actually giving me, they can actually give me some data on that, so I can look back and say, well, you know, 2 years ago we sent X amount onto the public wound clinic, and now we're sending Y amount on, and I think that's a pretty powerful story going forward for this. They report that they're engaged in learning about, the patients are engaged in learning about their wounds, self-management, etc. So it's a win-win-win, the patient outcomes, clinical professional development and affordability for the patient, for the practice and for the health system. And the take-home messages for us is, as Karen said, if you don't know who your local wound expert is, do a bit of digging around and find them. There's only 3 Nicolas in Australia, but there's a lot of wound management experts, and build a network with them. I've found that Warmer were really receptive to wanting to be used as a resource for general practice nurses. Don't be afraid to make local networks with your neighbouring practice, because there might be someone just next door to you who's been a part of this project. And as I said earlier, be aware of all things, and be aware of the hard sell techniques with your reps when they're coming through. I'm sure I'm preaching to the converted. Use your expertise and knowledge to educate the patient about wound etiology and lifestyle, and that will improve long-term outcomes for the people that we care for every day. And I'm going to hand over to Nicola, but before I do, I'd just like to reiterate, if you've got a weak stomach, just be prepared to go like this, because whenever she sends you something, you go, oh, yeah, okay, oh, that's all right. Okay, and then you get down to 2 more screens, oh, that's a bit, and then she just goes bang. So just, that's my warning for you. So handing over to Nicola.
I was glad there's no ribeye on the menu for lunch. I'll just do a quick plug on the background of ORMA. I just happen to be on the committee. There's a conference coming up in Brisbane on it's in September. You can't read when it's exactly on, but yeah, we'll look forward to that. If you just Google it, you'll find the conference. The Australian Wound Management Association. Yeah, we'll pass some flyers around for you. Now, I'm not too good with technology. Let's just see if... Oh, yeah, there we go. And the pointer...
Pointer's the top.
Oh, yeah. Wow, there we go. So, I just thought I'd talk about... I was contracted just for 3 hours a week at these clinics. So you needed to really condense 3 hours into a lot of information to a very short time frame. So if I really speak quickly today, I'm trying to condense a whole lot as well into my 20 minutes. So we were excited when we were trying to transfer that information of learning to the nurses by just doing basic ABPIs. Who has an ABPI in their practice? Oh, yeah, fantastic. Look, it's a rebatable item. It's also a predictor of mortality. If we're getting patients in with very low ABPIs, they should all be referred to usually a vascular surgeon, because that low denominator basically means they've got other comorbidities associated with that. All an ABPI is a blood pressure on the arm compared to a blood pressure on the leg. You would suspect my perfect blood pressure to be 120. My leg blood pressure should be the same within a systolic reading using a Doppler. Divide 120 into 120, a normal ABPI is 1. You can compress the limb anywhere between 0.8 and 1.2. Simple mathematics. So we taught the nurses within the practice to be able to do that, to know what they're looking for. Dopplers detect velocity of signals. Our fingers detect the pulses. We should be palpating every single limb that comes in there with an ulcer. We should be looking at every single diabetic's foot when they come into your practices and educating them on how to prevent wounds and ulcers. You're at the forefront. I'm jealous that I'm not on GP land because I love it. I'm in the tertiary centre because I know I can make a difference between those chronic sick patients in the tertiary area. So we looked at assessment, examination of limbs, examination of wounds, making diagnosis. So as nurse practitioners, we can make that diagnosis. We can biopsy. We can send people off for MRAs and X-rays and actually go through that holistic trajectory of assessment to healing. We looked at intervention plans, wound bed preparation. We need our wounds to be looking like ribeye steaks. Not like that little off diabetic foot there with the callus surrounding that looks like it's dropping dead. But we need to know how to clean those wounds up because there's no point putting a $50 Acticoat on something like that because it will never work. So the types of wounds that I saw in the clinics, here's a quick snapshot. The greatest amount there, as you can see, was skin tears. So a lot of patients were coming in. If your elderly come into your clinics with a skin tear, whether it be on the arm or the leg, you need to lift that flap, to irrigate that skin flap out, irrigate the wound out for debris, reproximate that flap with a Steri-Strip, and add a dressing that's going to stay on for a week. You may need to add a couple of layers of tubercular compression after you've palpated the pulses to prevent edema build-up and to get that edema so it doesn't get under that flap to prevent that from lifting off. And if you do that and do it well, then you prevent these chronic venous leg ulcers from happening. And that's what we're seeing time and time again is, oh no, the flap was cut off at the GP practice. And we thought, that they'll just heal it. Well, you can't heal it if they've got venous insufficiency underneath those limbs. So we're seeing a lot of skin tears, so treating them well is preventing that chronicity. We've got, where's my pointer up here? Diabetic foot that I'll talk about more. Neuropathic toes on a diabetic, that toe ended up coming off, it had osteomyelitis. If you're seeing toes that are not healing, get an X-ray, please. Because we see time and time again that it's, an antibiotic is not going to kill the osteomyelitis that's got to the tip of that toe. And if you see a moth-eaten tip, the toe generally needs to come off. We have, again, the diabetic foot, skin, venous leg ulcers. We've got post-traumatic wounds, burns, sebaceous cyst. This Indian gentleman may have had TB. We sent him back on a plane. We had a radiotherapy desquamation. Oh, he didn't have insurance, that was why. Scrotal abscesses and other traumas. So that just gives you a general list, and I'm sure you see these types of wounds every day. And they're wounds that you can easily manage and look after in your practices. But when you've done your assessments, how do you know which wound here is the one that you're going to refer on? Who would think you would refer this gentleman who's 61, he's a type 2 diabetic with a neuropathic right great toe ulcer, who's got an ABPI 1.6? Or would you refer the 75-year-old man who's a type 2 diabetic with an ABPI of 0.58? You'd refer that one. He's got a pulse, I forgot to add. This gentleman didn't have a pulse on his foot. So just because you've got a higher ABPI, so remember if our 120 on the arm and 120 on the leg gives 1, so if I ended up having 240 systolic pressure on the leg compared to the arm, is a reading of 2, isn't it? What that's telling you is that that blood pressure cuff on the artery is probably not being able to squeeze the artery shut because of calcification. It doesn't mean it's blocked. It just means that there's probably some atherosclerosis or calcification within that vessel that can't be closed. But they may have a pulse, and you still can compress them. But remember our reading 0.8 to 1.2 is normal. If it's below that trajectory, they've got signs of arterial insufficiency. He's got claudication in his calf. He's got angina of the calf muscle. He's a smoker. He's got pain. He's symptomatic. And we had to send him off for further arterial studies, and he had, as Patrice said, a fempot bypass graft. So knowing to look at the limb, to look at the pulses, and knowing when to refer is an important part of your assessment. Diabetic foot, neuropathic ulcer. He was a hospitalised patient and ended up, I can't remember what surgery, but he got a heel pressure injury. 2 years down the track with excision of the calcaneum for osteomyelitis, it still hasn't healed. So, look, I referred this person to a vascular surgeon who has an ultrasonic wound debrider. And I know from evidence of my experience in referring patients on is that that helps to aerosolise through an ultrasonic wave and uses aerosolation to bombard the debris through heat energy. And it cleans up the cavity through wound bed preparation. And we got that healed in a 3-month period. We don't do that alone. We do that in conjunction with the podiatrist, the physio. We got him into a non-weight-bearing boot with crutches. We sent him to a dietitian. We sent him to the high-risk diabetic foot clinic. So the patient does the healing. We only provide the armoury of services and devices that we assist the patient to heal. Here's the pilonidal sinus lad. 16 he was. He was morbidly obese, unfortunately, and I think what Karen's doing with her new project within nutrition and school-aged children, my God, she could have helped this man. Please go have a look at the flyers. I think it's such a great initiative. So at 16, he dropped out of school because of the smell and the exudate and the pain and the discomfort. He'd had it excised a couple of times, and in 2 months you can see that that wound hadn't healed. So we referred this lad off to Kerry Coleman, another nurse practitioner I love dearly at the Royal Brisbane, and we put on these fancy dressings that cost, I'm allowed to say, over around $200. But they provided those consumables, and we put that in the nasal cleft with a bit of antibacterial, taught the nurses how to put it on, and this healed in a very timely manner. I'm still waiting for the champagne for that one. Hey. And then this other lovely lady that Patrice was talking about who had the pressure injury for 2 years on her heel. Grade 2 pressure injury through the epidermis down to the dermis. Started off with quite a big area. Now through diligence care, wound bed preparation, the GP and the practice nurse went to her care facility, assessed how she was sleeping, looked at her wheelchair, looked at the equipment, educated the carers to elevate that limb when she was in bed. So all those multidisciplinary factors ended up, this slowly reduced over a time frame. It did take around 6 months to heal, but again with that diligence, that written instruction, the home visits, the wound bed, we used, in my practice, we use a lot of antimicrobial solutions. So when you're cleansing the limb, we use chlorhexidine pre-op sponges to get rid of the staph. We moisturise every limb. We use a prontosan soap, so prontosan's polymethylhexylene biguanide. It's a derivative of chlorhexidine. It kills bugs, but it's not toxic to healing. Leave it on the wound bed for 10 minutes, and it decontaminates everything. It's beautiful. So we do that. And then we're using different products, and I'm not a stickler for products. If you can tell me your aims of the wound, then you could use a multitude. And we, in this case, when it was looking a bit green, used some iodosorb paste. When it was looking nice and clean, we used a leave-in foam. But the key for this is not addressing, it's offloading the pressure. Now, this lady loved Mrs. Brown's Boys. Have you seen that program? Oh, my God. And so when we'd healed her, and she would keep going on and on that she was going off to see the Mrs. Brown's Boys. And on her last visit, this is what she told us. A great appreciation of our care, and I think my sentiments exactly. So what we're seeing and what I'm loving is this partnerships that we're starting to collaborate with. So from me in the tertiary centre, I can collaborate with the primary sector and the secondary levels as well. So you are at the catalyst of prevention. You're the risk stratifiers. You can detect when they need to be going on what pathways. And you can protect a lot of these comorbidities that we have to see in the hospital. And I think you know all what you do, so I don't need to carry on about that. But the types of wounds that I'm referring to the secondary tier level, so it's like Dr. Yelland. He has a clinic. I don't know if Judy's in the audience. I can't see her. He is taking a lot of our patients on that need specialist care with ultrasonic wound debridement, bandaging, conservative sharp wound debridement, topical negative therapies. We're providing those resources for him and his nurses to use and to put on adequately. They're stopping them all having to come to me in my clinics. We are stopping the use of antibiotics that are unnecessarily required. We are decreasing the amount of outpatient presentations and decreasing the amount of surgical procedures that are happening. So if we continue to provide these resources and have this collaborative arrangement, it's just a win-win in my eyes. But let me share with you my day-to-day experience with wounds. And here comes the pretty pictures. So you've got a 62-year-old diabetic neuropathic foot. So you can either have a neuropathic foot, a neuroischemic foot, or an ischemic foot under the diabetic realm. So here is neuropathic. He had a pulse. He wore a new shoe, he got a blister, didn't want to do anything about it. Next thing, he comes in septic, dehydrated, acute kidney injury, needs to be having an indwelling catheter, needs a renal team looking after him, he needs the endocrine, the infectious diseases teams to sort out his wounds, and he of course needed the vascular team. What do? We chop off most of his great toe and his forefoot to get rid of that infective process. So when you see your diabetics, they're VIPs. V standing for vasculature, I for infection, P for pressure offloading, and S for surgery. Because antibiotics do not cut it alone. They need to come into the tertiary centres and have IV antibiotics and often those parts of their body chipped off. If you have a diabetic in your clinic with a wound, they have a 30% propensity to having a minor or major amputation by just having a wound. So please deal with them correctly. Use your time principles, tissue, infection, moisture balance and edge migration. How are you going to close the wounds? How are you going to decide what products you're going to use? When they're necrotic here, so after the surgery, they often have dieback. That tissue dies, it's still infected. I do a lot of ultrasonic wound debridement in the tertiary centre myself by having to prevent further surgeries into the theatre. And also, so I do it for preventing surgery, preparing wound beds for grafting and limb salvage. And this is limb salvage here. We did send it off to the secondary tier for VAC and also further ultrasonic wound debridements. Oh, sorry. So, 49-year-old, another type 2 diabetic. If we could show these pictures to the diabetics that come into your surgery and say, mate, seriously, this does happen. This takes a good 3 months to get this to heal. And you spend a hell of a lot of time because he's 49, he's a truck driver, he's still paying tax, he's still got a family to look after. And he can at least do that with his leg. Maybe in 10 years he may not have it, but at least let's try and salvage it. And we've got these technologies now. This is a topical negative pressure with installation. So we put the Prontosan soak in, it goes into the cavity, sits in there, irrigates it, you program it every hour. So the aim of that is decontamination. And what we're seeing is 4 days of VeraFlow. Look at that tissue, it's getting much healthier, isn't it? Filling in, less black. And then it's about 12 days later, it's really starting to look good. We are now, by using this technology, getting patients out, whereas the length of stay was around about 26 days, we're getting them out in 10. And we're getting them out because we've got these other centres to give them to, and we know that they can be managed there well. And you can see that healing trajectory, 3 months back at work. Fantastic. And then the last nasty, obesity. This lady's over 200 kilograms. She ends up with blistering on her leg. She can't reach her legs. She can't reach her feet. You know, how are we going to manage these people, these bariatric people that can't get between their toes? So she comes in with a strep A pyrogens necrotizing fasciitis, a flesh-eating bug. She was so septic, she was nearly dead, basically, with organ failure. She was intubated. And we took a whole team of people to salvage this woman's life. She's in her 40s. So following multiple debridements, she ended up having multiple skin grafts. And then she, ends up having custom-made garments to keep those wounds healed. And we don't do this on our own, it's collaborative. And look, it was a good result with her life was saved. So when you're seeing wounds that patients are coming in with who have smoking histories of 60-odd years, you can start get them onto those smoking cessation programs. There's this old lady, when she came in, was beyond salvage and had a BKA. I mean, she was in her 80s, but the pain associated with that limb was just horrendous. And then this is Monday, no, what day was it? This was Friday, 35-year-old type 1 diabetic. Came with a blistered toe, and she had another wound on his other foot as well. But, I'll show you the picture. You might as well have got an axe and just chopped straight through the middle of his foot to release the pus. And I mean, we're working hard. I was supposed to be changing his VeraFlow today because I didn't get to change it yesterday, and I had arranged for the KCI rep to come in and you sort it out. And I'm glad to say there's less pus and it's it could be salvaged. But as practice nurses that are so influential, by getting people's blood glucose at an appropriate level, you can prevent symptoms of neuropathy by 30% in the later years. And you can help control, these poor people who are in denial within their disease processes. The Karamar report came out in 2009. Again, Medicare Locals and GP Division came up with this chronic wound model. And it talks about the 3 tiers. And I think by collaborating between those tiers, we're on a win-win. Here's the types of wounds I referred to the GP practices, or to Dr. Yellen's practice with Cheryl Frank. So again, these are mainly young diabetic feet who we know we need to try and salvage. And they've all healed beautifully. We send a lot of venous leg ulcers because they need compression bandaging done appropriately as well. But I'm sending a lot more of my patients to GP practices across the coast. I don't know if you've received any of them. And getting the reps to come in and provide the education material, the bandaging, and the practice bandaging like Coban, 2-layer compression bandage systems, that I think you can manage in your practices if we help you with that. So I'm hoping I'm on time. So the key messages, it's these partnerships, these learning partnerships. I have nurses coming into my clinics. I have an all-day clinic on a Tuesday at Robina. They come in, spend the day, learn how to assess, compress, debride, and take that back to your facility. It doesn't cost you anything. It just costs you your time. Cheryl Franken, Stephen Yellen, I think Karen's going to talk more about their clinic tomorrow. And they do the same with practice nurses. So please, contact us if you're wanting to get some more education. So these integrated partnerships are decreasing admissions, length of stay, decreasing surgical procedures, and antibiotic provisions by using good wound bed preparation, technological devices, and skill sets of those who've been trained to do it. And we're here to help you as well be trained. And if I just finish up with the brave to bold concept, you start getting a bit braver. And I'm so lucky that my surgeons support my choices. They hate wounds. They're so happy to give me them. And there's just too many, so I want to share the love now. So with these topical negative devices, look what we can do. Oops-a-daisy. Look what we can do here with this foot. You've got an open great toe amputation. By using a topical negative device, you can bring those margins and close it in 4 days to stop that from granulating up. And we're just starting contact casting for diabetic feet. So plantar ulcers on the base of the foot that the patients can't get off. Myself and here's our podiatrist, Yusuf, are putting casts on. And it's done with trepidation because no one's doing it that I know of, apart from in the Northern Territory. But as nurses who are leading clinics, I have upped my personal indemnity insurance. No, look, we're well supported and we get the patients consented to the trial. So, look, watch this space. There's some great learning resources for you on there with the Learning Hub from CRC. Wounds West has got great modules. They're free. You get certificates. They're all part of your learning process. And again, the Victoria Project are well ahead of us as well. But that's it from me. Thank you for your time.
Get myself organised here. Okay, so hi everybody. My name's Allison Oakes. I am a nurse at the Sandy Bay Clinic. Sandy Bay is a high socio-economic area in Tasmania. In the clinic that I work in, we have 10 GPs, 4 nurses, and a range of allied health providers. So we have a dietitian, we have an audiologist, we have a diabetes educator, the list goes on. So I've already lost my train of thought, can you believe that? Anyway, so this project, if you haven't quite understood what the process is yet, is that the Medicare local told me about this project and I was pretty keen. So that meant for me as a practice nurse, I got to have a nurse practitioner who'd done a master's in wound care to come and spend 4 hours a fortnight with us. And that's a huge opportunity, isn't it? I mean, to come and do that in your workplace with your patients. Now, she, like we're saying, tapping into that, the resources that are around you and the people that are the experts. She is a nurse in Tasmania that works at the wound clinic at our Royal Hobart Hospital. And she did this, she came to our clinic and that was funded by the government. So she was able to come along and that's how she was involved in it. So I applied to be a part of this. We were successful. And then I had to approach the practice manager and I had to sell it in a way that they were going to let us do it, because at the end of the day, we all know it's tough financially to get these things off the ground. So they were really supportive though. They said, absolutely, if you think this is going to improve things, go for it. So we did. So I started off with the wound clinic and I first started with 3 patients booked into the clinic. It didn't go so well because there was too many patients and not enough time for the education that we really wanted to grab hold of. So I reflected on that and then I thought the best way to do this is to have 1 patient booked into that 4-hour session, and that meant that you could really engage in that education. You had 4 hours dedicated. Now there's 4 nurses, so what I had to do was I had to then divvy that up between 4 nurses over 6 months. And that was really good. So we each had the opportunity to do this. But again, what I think is a big gap in wound care is consistency between nurses, because what I do, because I think that's good, somebody else might have a different opinion, or, you know, historically they've done it this way, so that's how they're going to do it. So I developed some learning objectives, because then that gave all the nurses and Lee, the wound expert, a guide to follow. And until you have these objectives, you don't really know what it is that you need to learn, do you? Because wound care is so huge. So I'll have to just name this up now. I'm certainly no wound expert. I thought I was quite good at wound care, actually, until I did this training and I realised enormous gaps in my knowledge. So I had a good understanding of wound products and the purpose of the products, but my assessment skills were missing. So if the assessment is missing, how do you manage with just the products? I don't know. Does everybody else feel like that? So this is how I tackled it. So I'm just going to go through the learning objectives that I set for the nurses to achieve. So now, whilst we all cringe at documentation, this actually probably is the most important part of this for us in general practice, for our clinic. So what we wanted to do was we wanted to become more familiar with completing the template on Medical Director. Now, if you just free text into Medical Director or into whatever software that you have, you don't get any consistency, because what I write isn't what the next person writes. And are you addressing all the aspects of wound care? Probably not. So having a template and a wound form is, I think, essential. And we didn't have one. Now we do. So you're getting consistency, and it's better communication. That is what was really important. So from me to the next nurse who came after, you could really see that I'd addressed all those areas. Importing a photo into Medical Director. So we had to set up a process of how we did that. And I'm happy to go through that, because it's really quite easy to do that, and it's so important, because how do you know what somebody was looking at last time and why they chose to change that dressing? You don't know unless there's a photo there. So, of course, to get consistency, again, everybody has to be doing that photo the same way. So we had one that was a photo that was, every photo had to be labelled with a ruler, with the date and the patient's initials and the location of the wound. The wounds were always photographed in the treatment room, so the same room, same lighting. You need a photo that's up close of the wound bed, and then a photo that is, say, 20 centimetres back, so that you're getting the surrounding skin, and then 30 centimetres back from that, so that you're actually getting the extremity in that photo as well. So by doing that, I think that we really did improve our documentation. Now, when I first started this education journey, I suppose, I really didn't understand all the terminology on the form. And so together, Lee, the nurse practitioner, and I used Google Images because really that is so helpful, because then that helps you identify, say, atrophy blanche or ankle flare. I didn't know what these things were. So if I Googled the image of it, then I was probably better off to, be able to recognise that in my next patient. So that was what we came up with as far as the documentation. So the next learning objective, am I going too slow over these? Is that okay? I don't know why I'm such a... Okay, this is a pretty huge one. So this was probably the biggest of all the objectives that we had to try and cover. So conducting a holistic assessment. Nurses are generally very good at doing that. We do that across all aspects of chronic disease management. But this has to be specific to wound care, and you have to be able to figure out what the red flags are that you're actually looking for. So when we say you conduct a holistic assessment identifying the risk factors for delayed wound healing, when you're talking about past medical history, what are your red flags? What is going to delay wound healing? Well, diabetes, obviously, we've seen that. Hypertension, autoimmune diseases, heart and lung disease. They're the sorts of things that you're wanting to red flag through that. Dietary intake, what is somebody eating? How much of that food are they actually eating? What's their weight like in the last 6 months? These are the sorts of things that you're going to have to cover to complete this wound assessment properly. Social history is important, so their current social history as well as perhaps their work history. Did they stand up for a long time as part of their job, for 50 odd years on a cement floor? Is that what they did? Was it a lady who had, big babies, and lots of them? Because all these things really do impact, and you have to be able to take a proper history. So again, performing an ABPI. So we heard about what that means and how to take an ABPI. We didn't know how to do that. We were lucky enough to be given a Huntley Duplex Ability is the name of the machine that we've got. And what's special about this machine is you don't have to rest the patient. So when you're doing a manual Doppler, you have to have the patient laying down flat for 30 minutes beforehand. Really, for us in general practice, that we don't have that kind of time. So this machine is worth it. It prints out the result for you and the waveform to go with it. So then you can bill for that time. If you're doing a manual Doppler, which we were beforehand, you know, you'd spend all this time, 45 minutes or more, doing this, and really you can't bill for it. So again, then obviously you have to use that to then plan your care. So we're talking about effective compression. Are we going to put enough compression on somebody, and is that compression appropriate for the patient? So then we're looking at the type of wound pain. Again, you're looking for the patient's story. Are they telling you that they're laying in bed of a night time and they can't tolerate the pain anymore, so they have to get up and walk around? What's that telling us? Is that telling us that it could be some sort of arterial disease? They're the sort of red flags that you're wanting to look for. Equipment is another thing. So I talked about the duplex ability. The other thing is the VesiTrack. So we were given a VesiTrack, which is, I don't know, does anybody have one of these in their practice? So it's a wound measurement device, and so we would do approximate wound measurements. So, you know, really, we were guessing. This machine has like a plastic slip over it. You trace around the wound, and then you transfer that tracing onto this machine. You trace around it again, and it gives you the exact measurements of the wound. And that is really useful because then, well, what I'm doing is consistently the same as what the next person is doing. We talked about measuring ankle and calf circumferences as part of a normal wound assessment, and so that is obviously measuring at the widest part of the calf and the narrowest part of the ankle. If you've got somebody in compression, when you're doing that, you'll soon know if they're being compliant with their stockings or not if you're measuring their ankles and calves. Feeling for pedal pulses, dorsalis pedis, posterior tibial, you want to make sure that you are palpating those and you're feeling those. Also, the monofilament screening. I don't know how many of you routinely do that with your wounds, but checking for sensation, it's fairly quick and easy test to do, but provides you with lots of information. This is more of a perhaps a skill than it is an objective for, you know, in the assessment, but the being able to apply some EMLA and debride those wounds. So we're talking about getting that wound bed back to being able to heal. And so you can't heal a wound if it's covered in slough, can you? So debriding is essential. And the only way you're going to know how to do that is if you seek out this education and upskill almost yourselves by tapping into these people that are in our community willing to help us. Again, of course, we talk about the wound bed, the depth, the edges, the exudate amount and type, the wound edges, the odour and the surrounding skin. So hopefully by the time you've done that part of the assessment, then you're able to differentiate between the types of wounds that you're looking at. So that was a big one. So the next one is the products. So we've sort of, I think everybody's got a grasp on this. So understanding the categories and what they're intended to do was a learning objective. However, there was one nurse in our clinic who this was really important to her. She didn't feel like she had a head around that. So again, if you set these objectives out, then you know that everybody's on the same page. Understanding appropriate referral process for wound care. So when do you need to refer this patient on to acute care settings, or when do you need to tap into other services, so podiatry and, like we were saying, physio or OT assessments. So utilising the best practice assessment tools. So in general practice, I think it's really important that we don't say it's because we've learnt it this way. It's if you're going to change something, if you're going to tell somebody this is how it should be, it has to be evidence-based, doesn't it? So you have to have the resources in your clinic to say, actually, no, this is how it needs to be done because the evidence supports that. So making sure that you have these resources about is very helpful. Okay. Here's a bit of a case study. So this is an example of how we would do an assessment or how we would document the care of a patient before we did this training. It's pretty simple. It takes one slide. There's not much to it, is there? Our assessment was a description of the wound bed only. That's not really that flash, and approximate guessing measurements. If we were really lucky in the notes, we would explain why we chose a certain product, what the aim of that was. So now if we look at the same patient, so same 75-year-old, after we had done this, so this is where it really changes. So now we start really addressing each aspect. And so if I was to go through this, you can have a look at it. The wound locations identified better. We're talking about what type of pain we've actually got. The wound measurements are more precise and accurate. The ankle and calf measurements are there. We checked the pedal pulses. We did the ABPI, so we said, okay, this guy's now got adequate arterial flow, and he's suitable for compression. So we documented all of this properly with photos, etc. So now you can even see that the wound bed is discussed in even more detail. So no, we're not just saying now what is that wound bed, we're saying what percentage is that, so that when next time somebody comes along they might say, well, actually now the granulation's 40% and we can see this progress. Then we go on and we continue to do a better job assessing each area. Now, if you were to free text again your wound assessments, you're not going to cover all this at all. It won't happen because you don't have the time and you don't have the prompts to document all of this. So I think that's really important to go through a process. Obviously our wound management plan changes dramatically. We've talked about the referral process, but the wound management plan changes. So now we're using compression. We use the Prontosan because that's obviously a very effective product. So obviously things are improving. So we've talked about this. We've talked about the evidence-based practice, having the resources there, and the patient education. That obviously is a really important part of that. And we used these resources that were provided in this research project, and the patients were really pleased with this. They felt better educated, more empowered. It was a much better outcome. So our patient progress. So in 4 months, the patient's wound really improved. The holistic approach to his care really made a big difference because all of a sudden we weren't just assessing his wound, we were thinking about his COPD and his assessment of that. So of course he got spirometry done and he got treatment for his COPD, whereas before that he was just short of breath. He then had iron infusions through the hospital because obviously he was anaemic, and so the list goes on. So obviously they healed faster and better, the patients were happier, so they're good outcomes on their own. One thing so now our changes to clinical practice. So obviously when you do some sort of education, then obviously you have to make changes, don't you? So we've talked about the photo, we've talked about the equipment and the skills that we all improved on. So we felt more confident, but as was discussed before, the GPs felt more comfortable with us. It also meant that the hospital-based wound clinic would then ring me and say, look, we have this patient that lives in your area, here's their history, can you continue on this care for this patient? Or the doctor might say to me, Alison, I have this patient in an aged care facility, I think it needs further assessment, we don't seem to be getting anywhere, can you go and have a look at it? So again, now you're sharing your knowledge around and being more useful and keeping patients out of acute settings because we can do this. We're capable of doing this. The learning objectives, I can't tell you how important they really were. So each nurse, again, there was consistency. We now have regular clinical meetings between the nurses at the practice so that we're sharing ideas and practising our skills. So we get out the 3-layered bandaging and we practice again so that none of us forget, and that's really important. Billing for wound care, I don't know how any of you do this, but it's it's certainly not a money spinner. In fact, a cost analysis that I did meant that we were losing about $20 per patient, and that's a lot. So what we did was, by improving that assessment and documentation, you've now got a 2-page assessment that you're doing every time. Now, the doctor's obviously overseeing that, so you're billing a 23 instead of a 3 because you're spending more time with them. Billing for dressings. It's the strangest thing, isn't it? We have certainly implemented that since then. The doctors don't write a script for the patient and then say, oh, but I'll pay for your medication. And it's the same with dressings. You can't absorb that cost anymore. So we came up with a billing slip that we give to each patient when we do their dressings, and we sell these dressings to them at cost price. We don't make anything from it, but we cover our costs. Now, reception hated this initially because obviously they have to do the rebate-only billing because otherwise Medicare won't accept it. So rebate only, and then you pay for your dressings separately to that. Obviously, utilising the 10997, the care plan item numbers and the ABPI item numbers helps to generate and cover costs of wound care. We've talked about the automatic Doppler and the other new equipment that we got. The other thing, by billing patients for their dressings, is I could now get dressings that were actually very useful dressings. That meant the wounds healed faster, that we were changing them less often, and I thought that was really important. How does this education continue? So obviously, we all need to keep up with our practice, and there's lots of opportunities for that. And seeking that kind of education is so important. Ringing up the hospital and saying, who's your wound care expert? Can I get in touch with them? Can I spend some time with them? It might be, at your cost in turning up and your time, but it's well worth it. The other thing that I decided to do was, now that I feel like I've got more knowledge in this area, I didn't want to keep that just in my practice. So I started a nurse network. It's going to be the first in Hobart. It may even be the first in Tasmania, I think. So what we were going to do in our first network meeting is go over wound assessment and compression bandaging and documentation. And Lee, who's the wound expert for us, said, I would love to come and be a part of this. So she's really keen. She's going to come along. She's going to teach now. I think we've got 16 or 17 nurses turning up for this first network meeting. So that's about my journey through this education, and it was well worth it. And if you ever have the opportunity, go for it.